Hmm.
We are live.
Hi, hello, and a very good morning. I welcome you all to today's session 2 of the AIOS GuruSangam, and we'll be discussing regarding the examination techniques. So it's a wonderful it's a wonderful session which has been introduced by Dr. Partha Biswas sir, President AIOS, Dr. Santosh Honawar sir, Honorary General Secretary, and Dr. Manoj Mathur sir, Honorary Treasurer as well. For the today's session, we have the speakers, Dr. Sahil Bandari from Guru Hasti Chikitsalya Jodhpur, Dr. Shweta Malagundla from Minto Ophthalmic Hospital and RIO, Bengaluru, Dr. Tasneem Suraya from Madurai Medical College, Dr. Shruti Hegde from Manipal Tata Medical College, Jamshedpur. The expert panel consists of Dr. Hemalata from Minto Ophthalmic Hospital, Bangalore, Dr. Nayana Poddar from TNMC and Nair Hospital, Mumbai, Dr. Prafulla Maharana sir from RP Center, AIMS, and Dr. Sanjeev Mittal from AIMS, Rishikesh. So today's topics will be on history taking and its applied aspects, slit lamp examination techniques, drawings and color coding in ophthalmology, tech-enabled self-directed learning, tools, strategies, and assessment models for the ophthalmology resident. And we, the moderators of the session, myself, Dr. Farnaz from Center for Sight, Hyderabad, and Dr. Rolika Bansal from Mahatma Gandhi Medical College, Jaipur. So with no further ado, let's begin today's first session by Dr. Sahil Bandari. Over to you, sir.
Thank you, Fanas. I'll just share my screen.
I think it's worth mentioning that the topics that have been chosen are extremely useful and helpful for the audience. So I hope that you all are able to take something good with you back home. So thank you to the speakers for agreeing on taking these important topics.
Thank you. At the outset, we would like to thank AIOS Guru Sangam for this opportunity, and I'm hopeful that this will add a lot of stars into the academic sessions of the AIOS per se. So I'll begin with the history taking. Uh, Obviously, history taking is a very important part of any clinical case presentation or maybe patient examination techniques or anything in a routine clinical scenario, clinical life. And as a clinician, this is the first thing which we start doing when a patient sits in front of you on either or the slit lamp or even when we take into the operation theater, we once asked the patient its demographics to verify. So this part is a very important part which begins in the very first point of interaction with the patient and leads us to a very important flow chart in the sense that we are able to come up to a multiple differentials and we are really able to sort the thing out in our mind in a flow chart basis so that we can diagnose the thing properly and obviously we can treat the patient accordingly. One important thing of history taking is of a very good history taking is that it builds up a good rapport with the patient because that is the only chair time, I suppose, when we can interact with the patient and we can build a rapport with the patient. So the general principles overall for history taking is very simple. You have to listen to the patient first and then put up your questions. Don't directly just put up your question or don't try to make it a shortcut or a bypass system. So until unless you listen to the patient and then tailor down your questions, the history taking is almost incomplete if it is not done this way. What all can be done into this? Well, history taking is not just asking complaints. Okay, history taking is starts from the very basic thing is like demographics of the patient, and it goes up till a detailed review about your systemic history, personal history, patient's personal history, a drug history, menstrual history, past history, everything. So one by one, I'll try to cover up these topics in a brief manner. I've tried to make it as exhaustive as possible, but obviously it is there will be few things which may be missing out. But I hope I'll be able to do justice to the topic. Starting with demographics. Every demographics, as we all know, that from the MBBS days, we were taught that each and everything, starting from the name, caste, even religion, and even age, sex, occupation, address, everything has its own significance. So in eye care also, it has its own significance. By the name, by the caste, creed, you can understand that what kind of you have a little difference in the type of diseases like retinal dystrophy. Can be more prone in consanguineous marriage age. You can have congenital cataracts, which can be more prone in consanguineous marriage. You can have malnutrition related, like vitamin A deficiency in low socioeconomic status people. So that way, you can have many other thing, many differentials which can come up to your mind when you take the demographics of the patient in. And considering age, obviously every age group has a different ocular pathology spectrum. Then regarding the sex, females are more prone for autoimmune, males are more prone for traumatic because of the agricultural work. If we talk about farmers, in the form of occupation, then again, farmers over here in Rajasthan, as we say, and even other places, fungal keratitis is very common. In welders, photokeratitis. Regarding address, obviously, you can patient may belong to an endemic area where trachoma, however, it is not very common, but yes, you may be able to see the byproducts or the sequelae of trachoma in such areas, as which may lead to dry eyes, moderate to severe dry eyes, but showing the signs of old signs of like scar and arch line and everything. Onchocerciasis, even tuberculosis. As in India, we have it is an endemic kind of thing. So tuberculosis can be there. Coming up to chief complaints. Now, this is the main time taking schedule of the history taking, and this needs a very good kind of a detailed history taking also, or detailed questioning also. So you can have multiple complaints ranging from diminution vision to deviation of the eyes. Eyes, one by one, we'll try to cover up them. Now, I've tried to do this justification in the sense that history taking, along with that, whatever differentials can come, common differentials can come up to your mind, that I have noted down in these also. So as per the complaints, and that will be the applied aspect. We'll start with the diminution of vision. So it can broadly be classified into three categories like onset, pain, and laterality. On that basis, we can say whether it is sudden onset or gradual. It can be painless or painful. It can be monocular, binocular. Now, each subset has its own differentials, but the patient can present with more than one thing. Obviously, it will patient will present with rather more than one thing. It will be sudden onset, can be painful and monocular vision, or can be gradual, painless, binocular. Both the things can happen. So when we talk about the onset, it is if it is sudden, you can have in your mind uh, corneal ulcer, glaucoma, trachoma, trauma, subluxation, or a dislocation, uveitis, vascular occlusions. So in that way, these are all the sudden onset defective vision. So we need to keep in mind when patient says sudden onset defective vision, and at least from anterior to posterior segment, you have a subset of differentials in your mind. Same way, if the patient says gradual, yes, you have cataract and refractive error, one of the most common. Then glaucoma, another one very common differential. Diabetic retinopathy. You can have drug toxicities or degeneration or dystrophy. And also you can have neurological illness, maybe the organic cause of visual loss, which can be in the form, which can present in a gradual form. When it comes to pain, if it is painless or it is painful, again, painless as a broad category, it can obviously overlap with the previously mentioned sudden or a gradual or onset of defective vision. Painful, we need to be again, we need to make sure that we try to evaluate the patient, and because that is a troubling thing to the patient when it comes to a painful. Also, it can be acute onset glaucoma, uh, secondary lens induced glaucoma. Even sometimes patient can present with sudden increase intumescence in the cataract, which can cause a mild pain also. So it is not necessary that painless. If it is cataract is painless, cataract cannot be painful, but it can be painful also, it can be painless also, but more or preferentially more it is in comes under painless category. Eh. Next comes is the laterality, the binocularity or monocular. Now both eyes or a single eye. So it can even this thing can overlap with diplopia, that is double vision also. But patient can obviously present with a defective vision in one eye or can present in defective vision in one eye more than the other eye. So when patient present with defective vision in both the eyes, the common differentials can be ocular surface disease like can be allergic conjunctivitis, eyes which can cause dryness and in turn can cause blurring of the vision and can be cataract, can be refractive error and glaucoma. I have tried to mention the common diagnosis first, differential, and after that I have tried to mention the less common differential diagnosis. When it comes to single eye having defective vision, it can be corneal ulcer from the NDA segment, that is corneal ulcer, to posterior segment optic neuritis, AION, RBN. Even though it is not necessary that optic neuritis, RBN cannot present bilaterally, but yes, that is a very rare scenario. Oh, but still we need to keep in mind in all these differentials when it comes to the complaints session. And headache. When we talk about the headache, it can be like now regarding headache, just one thing which I would like to highlight is for the residents. And it may appear like it's a simple thing, a simple, very simple complaint, and many times it can be overlapped, or you can sometimes we tend to ignore that thing. Okay, it is headache, but yes, headache. If we talk about headache and we go into leading questions, there can be not just one leading question. There can be multiple leading questions. You can ask whether it is unilateral, bilateral, at what time of the day, what intensity it is, what duration it does it last, is it having any localizing like it is a frontal or occipital one, does it have any associated symptoms, and is it related to some of the other professional activities like computer technicians, IT professionals, or even doctor, any professional who is using more of a computer, so that can be related to the screen time. It can be related to like jewelers, those who do micro works, or welders, those who do more work in during their light toxicity kind of thing. So that can give you a little differential that what can be the ocular cause of it. The common ones are refractive error. One very important thing is convergence insufficiency, which can start in very young age, like even 8 or 10 years or 11 years of kids. We can see convergence insufficiency to even up to 30 to 35 years of age of adults also. We can see convergence insufficiency, which many times goes misdiagnosed or undiagnosed. It can be intermittent exotropia, pre-presbyopic age, like around 35, 38, patient starts to, they don't have any near vision issues, but still, because they are continuously working at a near distance, they start to have headache. Then dryness, another one very common differential of headache. Papilledema, optic neuropathy, and glaucoma can present in varied form. Redness. Again, redness broadly we classify it into acute or chronic, or rather we would say it could be a diffuse conjunctival congestion, or it could be circumcorneal congestion. Based on that, and along with that, if we have associated any symptoms, or we have associated signs, and on that basis we can come to again some differentials. Like if we have redness, along with that itching is there, we can think about allergic. If we have redness along with a discharge, we can think about conjunctivitis. If the discharge is more of watery, we can think about viral. If it is more of a mucopurulent, we can think about bacterial. If it is associated with photophobia and it is not a diffuse, it is more of a circumcorneal, so it can be associated with uveitis. Right? If it is a sectoral, it can be associated with episcleritis, that is sectoral episcleritis, or if it is associated with certain, if it is more localized into the nasal aspect, it can be associated with moraxilla conjunctivitis, it can be associated with pinguiculitis, which can be associated with inflamed pterygium. And so the basis of the other complaints and the signs, we can come to multiple differential diagnosis on a simple point of redness. Pain. Mind you, one is headache, the second thing is ocular pain. So ocular pain associated with headache or ocular pain with or without headache, without headache also. Both the things can bring you to a particular differentials. As those differentials can be many. Like if you have a severe pain, it can be associated with scleritis, as JCA, and it can be associated with headache. Then it could be a migraine. It can also be associated, if the pain is associated with colored halos, or it can be associated with acute angle closure glaucoma or even migraine. If it is mild pain, it can simply be allergic conjunctivitis, it can be simply be a dryness, as or it can be a for concretion, presence of concretion or a foreign body. A important thing is there are some warning signs when they are associated with pain, especially the severe headache is associated with a warning sign. You can have some kind of aneurysmal issues. Oh, so that is the thing. It can be associated with some nerve palsy. If there's a pain and patient has a diplopia, then obviously there can be some nerve palsy, which could be a emergency point of view. So the important thing is to ask another associated symptom and look for some associated sign. And many times again, when we talk about mild pain, we tend to forget a very simple thing is dryness, as which can be due to screen time or maybe environmental thing. So that can cause dull aching pain. And so differentials like dryness or ocular surface disease should always be kept in mind for majority of the symptoms, be it headache, be it blurring of vision, be it pain. And as I spoke just two slides back about the redness, if it is associated with watering and discharge, as again, we need to note down the nature of it, whether it is continuously you are having the patient is having continuous watering, or it is intermittent in the sense maybe once in a day or maybe once in few days is it can be there. So that can change the scenario, because if we ask, if the patient says it is, I am having watery eyes or I am having watering, and we think about that, okay, we don't ask much of the question, we can miss out simple differences like CNLDO, NLDO in adults, and we can even miss out milder recurrent inflammatory disease if we don't ask the history of associated redness or associated pain or what kind of discharge it is associated with. The point of discharge is we I don't know how do we write or we document, how do the residents document in today's time, but yes, discharge need to be documented either in the form of watery, mucoid, purulent or a ropey, and the ropey discharge is typically associated with vernal keratoconjunctivitis or allergic conjunctivitis. It is watery discharge can be associated with viral or NLDO. It can mucoid can be associated with allergic or mild bacterial infections. Purulent can be associated with a very good bacterial infection, and constant watering, as I said, it can be associated with NLD. Next symptoms is photophobia, where again photophobia can be because of the uveitic issues, corneal issues, even intumescent cataract. Right. So intumescent cataract, acute congestive glaucomas should not be ruled out. Should be kept into a common differential. Also, mucopurulent conjunctivitis that can also cause colored halos to many of the patients. Yes, regarding colored halos, differentials. Also, how do we differentiate between the conjunctivitis and even acute congestive glaucoma and all? Also, what you can do is halo disappears. If it is glaucoma, it can disappear after instilling a drop of glycerol. And if it is cataract, and patient will have halos with clear cornea. If it is a mucopurulent conjunctivitis, patient if you ask the patient to close the eyes or maybe clean the eyes, the mucopurulent conjunctiva discharge will go off and the patient will have less of colored halos. Diplopia, again, monocular or binocular, or monocular can be corneal pathologies, can be lenticular pathologies. Binocular diplopia, again, more commonly nerve palsies, is but can be less common, could be myasthenia gravis or orbital diseases, is in the form of tumor. Visual symptoms, flashes, floaters, metamorphopsia. Like flashes, mainly you should look into the one fact that there can be some or the other form of traction on the retina. Floaters, some form of the vitreous degeneration. Both the things requires a very good retinal evaluation. Next is past ocular history. A past ocular history is a little difficult to take until the patient has gone a clear surgical or a clear trauma. So that becomes a little difficult for the patient to grasp from his or her memory that what happened in past with the eyes, or was the patient affected anyhow in a recent past or a older past. So in when we ask about ocular history, past ocular history, many times we have to put down leading questions to the patient in a very crisp and clear way, where whether did you have some kind of redness, recurrent redness, or some or the other form of trauma, minor trauma. Maybe we may have to ask one or two times extra, because sometimes patient remembers this ocular history after a certain point of time, or after maybe while you're taking the history, at the end of the history patient will remember back, okay, yes, I had that problem long back this way. Medical and surgical history, obviously systemic any illness which patient under had previously taken treatment for, and is the patient undergoing any particular treatment at this point of time. The differentials related to systemic disease are again many, cannot cover each and every point of the thing. But yes, systemic history, past or present, surgical history, past or present, is very important and to be noted. Drug and allergic history, obviously, this is there are two aspects to this. First of all, when we are going to give treatment, we need to be careful that patient has any drug allergy. Second thing, if the patient has some allergic history, then the patient is prone for certain diseases in the eye that we need to be careful about. Family history. The most common thing is in the family history is very important. Everybody, I think, any residents take a note of it, is about the glaucoma. Uh, Along with that, second other things are this retinal dystrophy, corneal dystrophy, or dystrophies of any sort. Uh, Plus, nowadays, like cataract, congenital cataract, even so the upcoming thing is the refractive error. If the family has anybody in the family member has glasses, whether medium, moderate, or high powers, then obviously the future generation is prone for it. Personal and occupational history. Well, again, it comes down majority to the addictions and or any bad social habits which can cause some or the other form of ocular toxicity or ocular disease in per se. Systemic review, yes, you can take a detailed history. What I have faced problem, like what I have faced, I am facing at this point of time also when we take history, it is difficult to bring out the systemic history if the patient is not undergoing any active treatment at this point of time. So many times we have to ask the patient the name of the disease. That did you have any tuberculosis? Did you have any long duration cough? Did you undergo any kind of treatment for or any pus pointing in the body or pus discharge in the body? Did you undergo any kind of treatment for back pain? Or do you have any kind of stiffness or any back pain? Or do you have even early morning when you wake up? Many times patient is in a mode of denial also. When patient comes up with milder complaints, patient does not think that these all history have any major significance. Recently, I had a patient who had recurrent redness and once in a year from once in a 6 months some duration, and patient had presented to us also earlier two times and took treatment, and then that's it, went off. He did not come up and on those visits. This was the third visit, and this time patient had hypopion, unilateral hypopion, almost white eye hypopion, less and routines 3 to 4 cells else, and posterior segment was normal. Also, at that point of time, when I was asking continuously the patient did not give any positive history. But when we did HLA-B27, it came out to be positive. So it is a difficult. The patient does not realize that recurrent redness can be pathological. Menstrual and obstetric history, obviously, if the patient is pregnancy status, we have to check patient. We have to check the any kind of contraception, any kind of hormonal therapy which is patient taking at this point of time, which can cause multiple ocular diseases. Is well, in brief, I have tried. What do we need? How do we flow about? We ask. We first let the patient give the complaints. Let the patient tell his or her part of the story. Because if you listen to that part of the story, most of your problems will be solved, or most of your differentials will come up. And if you are stuck up somewhere, maybe you can again listen on the next frequent follow-up visit. Patient, you can again discuss with the patient. Maybe patient will come out with the one more issue. Just hold on, sir. Abhishek, Abhishek, एक मिनट गेट क्लोज कर, गेट क्लोज कर. I'm audible again? Yes. Hello? Yes.
Yes, you are audible.
Yes.
You're audible, sir.
So when we talk about the patient and the story of the patient and can lead up to, I would say, missed out things, because routine complaints, routine history can be, we may come up to differentials in an easy way, but when we are stuck up somewhere, or we are not able to understand that why something is happening or why this is happening, then a detailed part of the history, or the story part of the, or the part of the patient takes up the importance. And so we should, in as a resident, or not even as a resident, even as a clinician, for the whole clinical professional life of ours, we should make sure that we give this particular phase, history taking, its due time. Because when we give it due time, it probably will reduce the unnecessarily, maybe probably investigation we can say, or maybe we can say that the undue misdiagnosis or underdiagnosis, or kind of long base treatment, or we may be able to avoid small or minor errors in the treatment, and we may be able to give a better uh, follow-up treatment, or we may be able to give a better management to the patient. Because even simple differentials like dryness, allergic conjunctivitis, which is probably very frequent, very common, and we tend to just give a basic diagnosis, or we tend to treat the patient in a hurry sometimes, can reduce our rapport with the patient. But the same way, same time, if we take up a little history, we give a little chair time to the patient, we can not just build rapport with the patient, but we can treat it adequately, timely, and in a much better way, I would guess. So these are the summary points at the end. Symptoms, key, and differentials are many. Most of the differentials keep overlapping each other. So one thing which we were always taught, and which presently I think every resident is being taught, is that whenever we think of differential, there are two things in eye. First, start from more common to less common. Second thing is start from anterior segment, or maybe you can say lid, or even adnexa, to the posterior segment up to the optic nerve or neurological. So that is the way which I have also tried to list, and I suppose most of the residents would be doing it that way. So I would say that cross-examination, proper history taking, and obviously reconfirm it again and again. And many times when we ask systemic history, patient may deny, which happens here in Rajasthan. I don't know about the other places. Here in Rajasthan, when we ask sugar BP hai kya, the patient clearly says no. When we ask again, do you take any medication? Are you taking some medication? गोली ले रहे हो क्या? बोले हाँ मैं शुगर की गोली ले रहा हूँ. तो उनका ये मतलब होता है कि basically sugar BP, when it is under control, it is not there. So we have to always reformulate the question to make sure that we get the correct desired answer. So that would be all. Thank you everyone for giving this opportunity. Welcome any questions or anything.
Thank you, sir. Thank you so much. In fact, the importance of history taking and the usual, after that only we go ahead with examination, and this cannot be overemphasized, especially when it is pertaining to examination and even in daily practice as well. So the topic is open for the discussion by the expert panelists. Dr. Sanjeev Kumar Mittal, sir, do you want to add few points?
Yeah, what Dr. Sahil actually made something very comprehensively, a clear thing. Am I audible clearly?
You're very much audible, sir. Please go on.
So it's very comprehensive talk. History taking is something very, very important thing. And that is, has been a dictum that 75% diagnosis is made when the moment you're interacting with the patient. So we start when interacting with the patient, simultaneously, we start looking at the patient. And this development of the rapport with the patient is very important. Like what Dr. Sahil emphasized, patient doesn't come up. So that is developing the rapport with the patient. That is very important, how you are addressing the patient, how you are talking with the patient, and taking the history definitely. And a little thing, several times in normal practice in OPDs, you see that several patients, those who have some refractive problems, either the glasses are not comfortable, not properly made. At times it happens even just the centering of the lenses is not correct, and patient is being treated for with the lubricants, and just empirically they are being given anything. So that is very important part. Like spectacle history is very, very important. And one should give actually real emphasis on this patient if the patient is using refractive glasses, or if maybe the patient is having some convergence deficiency or refractive error, but not using glasses. So those things sometimes lead to very vague symptoms, which most of the time in a crowded OPD, then one can ignore. So those things actually are very important. Thank you very much.
Okay.
Very true, sir.
Dr. Hemlata, ma'am, yeah, would you like to add something?
Yeah, I just wanted to add a point. Like, as we know, like eye is the window for many systemic diseases. So it's very important. A detailed eye examination and a history taking helps us to diagnose many systemic which we miss out. And also in a busy OPD, as sir mentioned, Sanjeev sir, retro-positive cases, I see many of them, they may deny the treatment history that they have been treated previously. So very important, whenever see an unusual presentation, so we have to go back and then again collect the data whether they are on long-term systemic medications, have been any other treatment they have been. So that I would like to add on. Thank you.
Thank you. So, in fact, I think tuberculosis history is also like very important along with retropositivity, because from my UG, then PG, and currently in fellowship also, especially in retina cases, it turns out to be so important because when we suspect choroidal mass, we always tend to ask like, okay, is there a TB history to rule out choroidal granuloma and all? All right, thank you so much. So with no further ado, we'll move on to the next talk of the session, slit lamp examination techniques by Dr. Shweta.
Yeah. Thank you. I'll be sharing my screen now.
Yeah.
A very good morning, everyone. At the outset, I would like to thank GuruSangam AIOS for this opportunity for the third consecutive year. So I'll be talking on slit lamp examination techniques. After a wonderful session on history taking, which is like the hallmark of any examination case, 75% of the diagnosis, as sir said, should be made at the level of history. And also because the eyes cannot see what the mind doesn't know. So if there's a provisional diagnosis at the level of history, that is when we start to examine the patient and to know what exactly to see. And there's no financial interest. Slit lamp is one instrument where it is used worldwide in almost every eye clinic. It is the basic instrument to start any eye clinic, to know the structures, to dig deep into ophthalmology. So it is basically a biomicroscope which has a high intensity adjustable light source. and which focuses a thin focused beam of light into the eye. From the time von Helmholtz introduced the concept of illuminating the eye to get more details way back in 1880, the slit lamp has evolved. And it is only after 25 years, that is in 1911, when Alvar Gerlstand invented the slit lamp biomicroscope. It was used initially with a Nernst lamp with a slit. And this has been awarded the Nobel Prize for Medicine in the year 1911. And here's a mention to say that he's the only ophthalmologist who got a Nobel Prize. And this was the basic slit lamp model which was designed then. And only after 8 years, the first commercially available slit lamp was introduced in the year 1990 by Zeiss. And after that, after maybe around 30 to 40 years, various inventions and introductions have been made as accessories, as other examination modes of slit lamp, as in Goldman applanation tonometry, like when initially a Hackstreet model was introduced, and then around 1950 to 1960, a revolutionary change in the measurement of intraocular pressure of the eye by introduction of Goldman applanation tonometry. So after this, there have been so many advances either in the imaging technique. Initially, slit lamps were used only for examination. These days, it has been used more, not just for examination, it's also for documentation and digital imaging and saving of the medical records. So digital imaging and other accessories to slit lamp have been introduced. So before we dig into the how to examine by slit lamp, we have to know the parts of the slit lamp. There is an illumination beam, that is an observer system and a mechanical system. So these are the three parts of the slit lamp, basically. So this illumination beam has got a light source where there is this light source has got either it is a halogen bulb or an LED bulb. Earlier it was a halogen bulb. Now most of the slit lamps have an LED bulb. And there's a slit height control where we can adjust the height of the slit lamp beam. And then there is a diffuser, which we can use to this is basically used to image the finding. And there is a condensing prism below this light source and filters. There are various kind of filters. Basically, the most common or neutral density filter, which is identified by a circle with a hash inside it, which is used in patients who have photophobia. Red-free filters, which is represented by a green circle, and which is used for for retinal examination, and cobalt blue filter for staining, fluorescent staining of the cornea, and anterior segment examination for Siedel's test, epithelial defect, applanation tonometry, all these things, this cobalt blue filter is used. And there's a decentration knob at the base of this illumination beam, which is used in indirect and retro illumination, which we will discuss further. So there is also an adjustment for tilting infused slit lamps. This is basically to minimize the reflections in the slit lamp. So this is just a small video to show. So this is the illumination beam, and this is the observer beam, and this is the mechanical support system, which has a joystick. And in this illumination beam, this is the light source. This has got filters here. This is the slit height adjustment knob, and this is the slit width adjustment knob. So this is the one which we use to adjust this width of the slit. So there is a diffuser here. This is a reflecting mirror, and there's a diffuser here. This diffuser is used in imaging the anterior segment. So it reduces the reflections of the light over the anterior surface of the cornea. And then you have other filters. So this is a white filter, then a neutral density filter, a cobalt blue filter, and a red filter. And this is the one which is used to, this is a measuring graticule. So as you can see, it is measured, whether you can measure the height of the epithelial defect, the maximum extent of the epithelial defect, and all can be measured with this. So then you have the observer system, which is basically a compound microscope. which has an objective lens, which has two plano-convex lenses with a total power of plus 22 diopters, an eyepiece with a plus 10 diopters lens, and which converges to give a 10 to 15 degree of stereopsis. And there are prisms placed between the objective lens and the eyepiece. So basically, as it's a compound microscope, it inverses the image. So it reinverts the image for us to see. So the magnification systems can be from 6x to 40x. Whether you're using a 2-step slit lamp, 3-step slit lamp, or 5-step slit lamp depends on what type of magnification you have. It can be 10x and 16x in one slit lamp, or it can be 10, 16, and 25 in some slit lamps, and it can be up to 40x in few specialized slit lamps. So these magnification systems are of three types: Zapke scope, Galilean system, and zoom systems. In these Zapke scope and Galilean systems, the change in the magnification will be exactly from 6x to 10x. There will be no intermediate magnification. Whereas in zoom systems, there is an intermediate. As you go on zooming it, there is an increase in the magnification. It's not exactly 6x, 10x, 16, 25, or 40x. There is an in-between magnification. And there is also an yellow filter which can improve the contrast, which is used in digital imaging systems. So the techniques which are used are diffuse illumination, direct focal illumination, moderate parallelepiped, narrow beam in optical section, conical beam, indirect illumination, retroillumination either by iris or fundus, specular reflection, sclerotic scatter, and oscillating illumination of Koeppe. As we say, as the mind cannot see, as the eyes cannot see what the mind doesn't know, what you see at the slit lamp is only as good as the illumination technique you choose. There can be multiple things in the cornea, in the iris, in the lens, and in the fundus. But what type of illumination you choose depends. It actually has a lot of bearing on how you are examining the structure and how you are describing the particular lesion. So before we go into the exact techniques, what are the other things that you have to see before actually doing the examination? Patient adjustment, instrument adjustment, and slit lamp examination. Patient adjustment. See, this patient adjustment can be different in a chair unit slit lamp or in a unit where there is a stool. So if the patient is being seated on a stool, especially in bilaterally blind patients, it's very important to make to give assistance to the patient to be seated in front of the slit lamp. They might bang on the slit lamp and get hurt. So it is important that there are two people who hold the hand of the patient and then make the patient sit laterally and then turn towards the slit lamp so that they don't get hurt. And also in chair units, it is very difficult if the patient is too short or too tall, or in sometimes obese patients, it's again difficult. So a lot of adjustments are required when we make the patient sit and make the patient feel comfortable. The chin rest height has to be adjusted. As I showed you, there's a canthal marking at the patient support system. Then a forehead rest, the patient's forehead has to touch the forehead rest, and the canthus positioning is important. So instrument adjustment. After the patient is being seated, after you have explained what you're going to do, then because patient cooperation is important, adjust the interpupillary distance. It is a binocular examination most of the times, unless and until it's a specular examination, where it is most often it is uniocular. Though you're using both the eyes, you'll be actually seeing with only one eye in specular. But most of the times it's a binocular examination. Observe it with spectacles, push the eye cups in, and without spectacles, the eye cups to be put out to maintain the distance. And neutralize the refraction before the examination. So these if you're wearing glasses, it has to be kept at 0 because you're already your refraction is already corrected. But if you're not wearing glass and if you have a minor refractive error, that has to be corrected along the eyepiece. And the mechanical arrangement, the instrument base, it should be moved with the help of joystick for three-dimensional view of three-dimensional examination. Now coming into the examination proper, diffuse illumination is the first one. Basically, it is used for gross examination of lids, lashes, conjunctiva, sclera, pupil, and iris. The setup is basically, it is angle between the illumination beam and the microscope, where it's around 30 to 45 degrees. How to apply it? Slit width is maintained as the widest and the diffuse filter. The magnification is low to medium and illumination is medium to high. So this gives a gross examination of the anterior segment. So this is a wide beam where you can see the whole of the anterior segment per se. So these are few examples where diffuse illumination gives so many findings. This is nothing but a magnified torchlight examination, but again with a higher illumination. So this is in the first picture, you can see a large corneal ulcer, but before that you see how these meibomian gland orifices are highlighted here. These obstruction of the meibomian glands, the conjunctival diffuse conjunctival congestion, and what is the extent of the corneal ulcer here. And again, in this picture, it's a healing corneal ulcer with a central perforation, which is again, there is a pseudocornea being formed. You examine the lids here, again, there's some amount of meibomian gland dysfunction, but the congestion is not very much. So it's also important to see cases where they seem to be very normal on torchlight examination. And if you directly jump into a narrow width examination, these are things which you're going to miss. This is one example where you see a case of correctopia and iris illumination defects. So this is a case of ICE syndrome, which you're going to miss if you directly put a narrow beam. So this is again a diffuse illumination of a graft. You can appreciate the infiltrates and a healing infiltrate and the suture markings, the clarity of the graft, whether there are any vessels growing into the graft, all these things. And in scleritis, whether there is any thinning of the sclera, what is the extent of the thinning, and what is the extent of corneal thinning. It gives a gross picture, and the clarity of the graft, the suture placement, and also for your photographic imaging, most of the times a diffuse illumination is used to convey the picture. If you want to convey the image, to ask for any opinion or for anything, this has to be the way it has to be taken. So all these structures have to be covered. Then coming to the direct focal illumination, moderate width. So direct focal illumination is again of moderate width and narrow width. In moderate width, it actually provides a high contrast field. So it is used in examining the tear film, the cornea and the lens, the anterior chamber, and retinal examination also using special lenses. The setup is medium to high intensity light. Slit width has to be 1.5 millimeter to 2 millimeter, and angle has to be 30 to 50 degrees. And for corneal examination in moderate width, use a magnification of 16 to 25x, and for lens examination, use a 10x magnification. So what are the specific advantages of this direct focal illumination is, it provides an adequate field of view under direct illumination. It also provides a secondary field in the adjacent illuminated area and gives a three-dimensional view in parallelepiped. Parallelepiped is nothing but a direct focal illumination of moderate width of light. How to apply? First, you focus on the eye, move the focus on the cornea, then concentrate on the tear film. Now, here you observe that the iris is out of the focus. So it is a direct examination of the cornea, basically focusing on the anterior tear film first, and then having a moderate slit width. So there can be errors in doing this. Too bright light can cause discomfort to the patient, and too less light can obscure the findings. So this is a parallelepiped examination. You can see that there's a three-dimensional view. So this is the anterior surface, the posterior surface, and this is a three-dimensional view. You can see the copper deposition in the peripheral cornea seen in KF ring. And this is the parallelepiped of the lens, where you can see the layers of the lens. Here the cornea is out of focus. Here it is the lens which is in focus. And again, this is the parallelepiped section of the cornea, where there are so many opacities and irregularities in the posterior corneal surface. Next is the direct illumination with narrow width or optical section. It's also called optical section. So the illumination principle here is basically, it optically dissects the semi-transparent tissues of the eye. So it is used to examine the cornea, lens, conjunctival nodules, and scleral nodules. So the setup is high intensity light, slit width smaller than 0.1 millimeter, and an illumination angle of 30 to 50 degrees, and a magnification of 10x to 25x. So it's a very small slit that you're going to use here. Basically, it is a CT section of the cornea or whatever the structure you want to see. So it is to know the profile, the thickness, what is exactly happening along the depth of a particular tissue, because it optically dissects a tissue. So what are the specific advantages? It gives changes in the profile or thickness of tissue, as I already told, and localized alterations. And how to exactly apply this? Move the slit lamp towards the patient, then focus the iris decrease the width and increase the illumination by moving the joystick towards you and increase the angle. So basically, you are focusing on the iris and then moving the joystick towards you so that it focuses on the cornea, increase the illumination, and if you want, you can increase the angle here. So due to the very small field of view, there can be errors because it can miss small alterations. So you cannot directly jump into optical section. Basically, after a diffuse illumination, see a particular lesion on moderate width and then shift the focus to the optical section so that you know the depth of the lesion. So this is an optical section where you see a desmetocele. See here, the width is very, very less. It's just 0.1 millimeter. But what you're actually seeing here, there's a change in the contour or the profile of the cornea, and there is reduction in the thickness. And again, in this picture, it is post-DSEC, whether the graft is in situ. In the post-operative day, you do an optical section and see whether the graft is in situ, whether it is attached or not. Again, in this picture, you see an optical section. The same optical section is being thrown on the lens, but if you focus the optical section on the lens, you can see that there's a small bulge of the cornea here. It is a case of lenticonus. So this optical section actually helps in determining the profile of the tissues. That is the main specific advantage of optical section, and also to determine the thickness of the tissues. This is again a post-DSEC case where you can see the posterior layer, posterior endothelial graft being in situ. And again, an example where you see the profile of the tissue here. There's a clear bulge here. So there is a central scar, which is not very much appreciated in optical section. This is one error. See, you can miss this epithelial scarring if you just see the optical section. So this section is only used to see whether there is any profile change and see the difference in the thickness between the superior part of the optical section and the central part of the optical section. So there is a large difference here. There's an ectasia, there is thinning of the cornea in the center. So these are specific advantages of optical section. You can examine the cornea, you can examine the lens, you can use it in post-operative cases, not just in DSEC, in also post-operative suspected decimates detachment. And next type of examination is conical beam. So you keep the biomicroscope straight ahead. The illumination angle is around 45 to 60 degrees. The magnification used is around 16x. Use a very small beam around height of around 2 millimeters. And sorry for the spelling error, focus between the cornea and the lens. And you observe the path between the optical path which is going between the cornea and the lens. This is the area of interest here. This is what you see in conical beam. This is specifically used for anterior chamber cells or flare. The magnification here mentioned here is very important because the number of cells and flare, what you mention in Sun classification is based on the 16x classification, 16x high power field. So when they say so many cells per high power field, it is basically the 16x. So once you focus this conical beam, don't change the field because it is per high power field that the number of cells are being counted. Then comes retroillumination. The basic principle here is it illuminates objects with light reflected from the structures behind it. So basically, you are not using the light which is exactly being thrown on the area of interest. You are using something which is coming reflected back and then view the structure or the area of interest. It can be direct retroillumination or indirect retroillumination, which I'll be describing later. So it is used to see the corneal irregularities, limbal vessels, iris transillumination defects, lens opacities, and contact lens fitting. It can be from the iris, which is seen in medium to high. The setup is use a medium to high light intensity, slit width of 1.5 to 2 millimeters, and an angulation of 30 to 50 degrees, and a magnification of 16x to 40x. If you are using a fundal retroillumination, use a low intensity light with it is almost coaxial. The angulation between the illumination and the observation beam is around 0 to 10 degrees, and with a magnification of just 10x. So how to apply? Focus on the area of interest and illuminate the structures behind. Basically, you use a decoupler here to focus on the the area of interest. You can use a decoupler in case of retroillumination. So the specific advantages are basically it uses the light phenomenon of refraction and absorption. That is why it is able to delineate what is perfusion of limbal vessels, what are the refractive changes in corneal tissue, foreign bodies, iris transillumination, and the patency of a peripheral iridotomy. Common errors: if an adequate distance is not maintained between the corneal slit and retroillumination, some findings can be missed. And overexposure or a very high intensity retroillumination, you can again miss so many findings. So this is one example where there's a history of trauma. This is what you see on diffuse or direct illumination. But if you use a a retroillumination from the iris, this is how the descemet is being delineated with all the pigment deposition there. You see the difference in the way how the structure looks once we use a retroillumination. So this is again an indirect retroillumination where you're not seeing this structure, but the area adjacent to it. So there are so many, I don't know whether it is clear or not, but there are so many small microcysts on the epithelium of the cornea. There is an epithelial microcystic edema here. And this is a non-transparent or an opaque foreign body, which again is magnified or being very clearly seen on retroillumination. And also a transparent foreign body like a glass particle can also be seen. So this is a direct retroillumination again, where you see the structure just coming right from the iris, but this is from an indirect retroillumination. You're not exactly seeing here, but seeing the structures just next to the dark area. So when you use a fundal retroillumination, always use light of low to moderate intensity, slit width of 2 millimeters, and an illumination angle of 0 to 10, as I already told. It's in the coaxial beam, and the magnification of just 10x. So these are a few examples of fundal retroillumination, especially patients, young patients coming to you with diminution of vision or glare or difficulty when following in daylight. You see, you dilate the pupil and see the patient on retroillumination to look for any posterior subcapsular cataracts. These are transillumination defects of the iris. And these are one structure where these two pictures, you see the difference. There are limbal vessels here. But when you see through direct illumination, this is the clarity. But when you see through the fundal retroillumination, this gives the caliber of the vessel. Sometimes you can appreciate whether they are live or they are ghost vessels. The next illumination is sclerotic scatter. The principle is it uses cornea as a light conducting medium. It is used in overall examination of the cornea and also in imaging. And the light intensity which is used is moderate to high. Slit width is 1 to 2 millimeters. The angle is 70 degrees. And here you decouple the beam so that the light falls exactly at the limbus. The magnification here used is 6 to 10x. And how do we apply the sclerotic scatter? Focus on the cornea, decouple the knob, and position the beam on the limbus, and tighten don't forget to tighten the decoupling knob because you can again defocus. So this is how sclerotic scatter looks. You put a beam of light. You first focus on the cornea and then get the beam of light exactly at the limbus. Adjust the illumination and light intensity so that it creates a halo around the cornea. So you see the halo around the cornea. It is creating a halo here. So that means you're doing a sclerotic scatter. You can see the opacities which are being clearly seen. And it gives an overview of the overall cornea. Next illumination is indirect, also called as proximal illumination. In this, the principle is light scatters into adjacent tissue to provide secondary field of examination. So this is a direct field, but this is secondary field. So this is what you are seeing in indirect illumination. It is used to see the lid margins, conjunctiva, corneal nimbus, or any corneal opacity. Setup is angle of 30 to 50 degrees and a magnification of 10x to 16x. Specific advantages it provides qualitative assessment of the translucent tissue. Here in case of a conjunctival cyst, or you can see episcleritis nodules on the conjunctiva, and provides field with a reduced light. So if there is any fluid, you can easily make out with the help of this indirect illumination. So how to apply? Observe the field just adjacent to the directly illuminated area. There is nothing specific here. So one specific area of a specific one is the indirect or specular reflection. Here, the field of examination is in directly reflected light. So the principle here is total internal reflection. So the angle of incidence is equal to the angle of reflection. So you make use of this principle and use the reflected light to examine the structures in front of it. So here though it is specifically used to examine the corneal endothelium, it can also be used to examine the tear film, lipid layer of cornea, and also the corneal wettability. Use a low intensity light, width of more than 1 millimeter, angle of 50 to 60 degrees, and a magnification depending on the structure that you want to see. So illumination angle need to be equivalent to the observation angle. Adjust until the reflected beam is observed. This is how to apply the slit lamp setting. Specific advantages, it gives subtle changes on the ocular surface and the endothelium. So how do you look for endothelium on specular reflection? First, you create an optical section of cornea and increase the angle of illumination to 50 to 60 degrees. It's a wider angle between the illumination and the observer beam, and move the illumination angle until you have a specular reflection. First, you should be able to see the Purkinje image of the light bulb, the first Purkinje image that you should be able to see, and then widen the slit width and increase the magnification to 40x. So this is how you basically see. So this is a setting. Once you put an optical section, you move the beam and adjust the angle. You increase the angle and then increase the magnification. So this is how the beam looks like. So this is the reflected light. You see that reflected light, the illumination has to be adjusted such that you see this reflected light, and then you examine the area just next to the reflected light. So this is the area of interest. So now you can see the endothelium there. This is the area of interest. You are looking at an area which is adjacent to that. Once you get used to doing specular reflection very often in your practice, you'll also be able to image it and photograph it by using a simple smartphone. So this is the reflected light. The area of interest is just next to this reflected light. So you see, you can also use an adapter to keep your hand stable. So these are the endothelial cells which are visualized. So you can see the enlarged endothelial cells and few guttae there. It is very easy to lose the focus here because the width and the height of the beam is very less, and you're using a very high magnification here. So more and more practice will definitely make you capable of looking at the endothelium. So these are the few things which, so this is the reflected light here. So this is a reflected light here, and then you see the images. So that's about the examination techniques that we have. And we also have a lot of slit lamp accessories like applanation tonometry, gonioscopy, pachymetry, anter-segment imaging, slit lamp videography, laser interferometry, ND-YAG laser capsulotomy, YAG peripheral iridotomy, PRP, and potential acutometer. These are the accessories which can be placed on the slit lamp. Thank you for your kind attention.
Thank you so much, Dr. Shweta. It was indeed an extensive coverage on all these slit lamp examination techniques. And definitely when we enter our post-graduation in the first year, we are taught all these slit lamp examination techniques. Meanwhile, when we go for a practical, we tend to forget all the nuances which are there, like what is this technique? Because we do not use few techniques in day-to-day practice. And again, it is revised for practical. So, and it's indeed a very important topic for the Viva examination. All right. So the topic is open for discussion by the expert panelists. Dr. Hemalata ma'am, do you want to add few points?
Dr. Shweta well demonstrated, and as well she showed all the videos of different sections and its utilization clinically. I would like to add, only thing is the postgraduate, as you told, they should read out, take the help of the seniors, and they have to do in front of the teachers once. Then they can practice on their own. So each thing was well demonstrated. I appreciate Dr. Shweta for an excellent talk.
Thank you. Thank you.
I would like to just add something to what Dr. Seta said. She had done very nicely, covered up everything, nothing left, I think. But only thing, just to emphasize more, I would like to say it is something like a slit lamp is like what is a stethoscope is for physicians. So it's a mandatory tool. It's just the residents should feel it. It's just like a toy. They should play with it, because when they play, they will have more interest into it. And one should remember, like for residents, that at least the moment they see the patient in OPD, mandatorily every patient should be seen on a slit lamp. Like even suppose a patient has come even just for just itching in the eyes or just some foreign body sensation. So just should not ignore like there's a crowd. But patient once have come to OPD, patient should be sat on a slit lamp. This should be mandatory thing. And the second thing, like what Dr. Shiveta mentioned about the patient's sitting comfort. This is something very important thing that she highlighted here very nicely. I mean, just little things because patient is not comfortably sitting. Like we just noticed sometimes the one very senior old patient came and then she mentioned that doctor, your stools are actually on the top steel stools and we are very old. It really pains us. So it should have some sponge that Dunlop cover over it. So those little things actually it makes comfortable for the patient to sitting and for prolonged examination. So thank you very much.
Yeah, and also
Thank
one
you.
more point. Yeah, if is it okay to speak? Yeah.
Yeah,
Yes,
please.
please, please.
Yeah. I just want to add on one more point. I mean, retinal examination point of view. So we should not be happy with only indirect examination. All the RD patients has to be seen in the slit lamp for macular status, because either it's in 1/3 of the case I've seen in my clinical practice, either it's associated with CME with RD or a macular hole with RD. So again, this being a depth perception, binocular vision, we have to utilize slit lamp examination. That I would just like to emphasize on the students.
Thank you, ma'am.
Can I
Dr.
add?
Naina. Yeah, yes, ma'am.
Yeah, hi. Excellent presentation, and she has really, described it with optical diagrams to make it very easy. And she's taken pains to put in videos, excellent. And as Dr. Sanjeev Mittal said, that I feel it should be a habit. The resident should be, encouraged to see each and every patient on slit lamp. And initially, if the patient is not comfortable, we can put a small drop of paracane and make the patient comfortable, but learn all the techniques. Start with diffuse, go to focal and optical. I think this is what has to be done now, a habit. Thank you.
That's true, ma'am. Like even when my residents are examining, I tell them to go for all seven first. I like just go with all possible techniques and then give me a diagnosis. That means because they'll end up missing the corneal findings most often. So it's very important for them to go step by step. Later it becomes a practice for sure.
So, yes.
Yeah, one thing I want to add is like the slit lamp examination, residents have to take use of cataract workup while doing cataract workup. Do all modes of examination as the previous doctor said. So you have, it is not just the lens grading what we do in a cataract workup. You see all the structures around surrounding, whether, of course, examination of the lids, conjunctiva, adnexa is important in a cataract workup, but we can make use of, gonioscopy, all these things need not have to be in a glaucoma specialty to actually to be a good comprehensive ophthalmologist. Just during a cataract workup, all these things can be done and can be pioneered once we do more and more slit lamp examination. There are so many things which I was not able to cover, like an Allen-Matsky test in macular hole examination, like how important they are just in a routine OPD screening. So it's very important, and it's a joy to see the structures behaving differently in different types of illuminations. So all are like quite important. Thank you.
Right.
Thank you for this opportunity.
Ma'am, that is such a good point, and actually, that's what I would like to emphasize. Thank God you brought it up. That ma'am said right that what your mind knows, what your eyes see, what your mind knows. Correct. So I landed up, just for example, I landed up telling the residents that you're not looking at everything. You're just looking at going for the cataract. And I started teaching them a little bit about different diseases that can happen in like lid, or maybe since I'm oncology, I started teaching them about the tumors that could be there and the plasty findings. Now they come back and they go like, ma'am, this one has this too. I'm like, okay, thank God you guys are going beyond cataract now. So I think it's about just letting them know and they will end up finding it for sure.
Yeah,
Thank
I
you.
think there is one question in the chat box. Dr. Shweta, you can take. How do you do the decoupling slit
Yeah,
lamp
I
examination?
showed you if I can share the presentation again. So there's a decoupling knob. Just a minute.
That
Can I
is
share the presentation
like
again?
X-ray
Yes, ma'am,
model
sure.
only, no?
Pardon, sir?
Is that decoupling knob specific to the head street model?
No, sir, it is there in all. Like, you just have to, there's a knob in the illumination beam itself. So this is the decoupling knob. So like, this is the knob here. So you just rotate it and then it becomes, actually I have a video of the decoupling, but I was not able to put because it takes more time. So it is actually, it just tilts to left and right once you decouple it. So it is very useful in sclerotic scatter, because sclerotic scatter is one thing which I have found it difficult rather than specular reflection, because we will not be able to focus the slit beam exactly at the limbus. So if we use this decoupler, just loosen it and tilt the beam left to right. So it will go wherever you want. Wherever you want to position the beam, it will go. So this is the decoupling knob. It is there in almost all slit lamps. Only the positioning might be difficult. That might be different. In Zeiss, it might be and in another one. So this is a decoupling knob.
Okay, ma'am.
Okay. Thank you so much. So, Dr. Tasneem will be joining us last. So, we'll move on to the next lecture of the session. I invite Dr. Shruti Hegde for her talk on tech-enabled self-directed learning tools, strategies, and assessment models for the ophthalmology resident. Over to you, ma'am.
Yeah, Dr. Shweta, can you stop sharing?
Yes. Yeah.
Okay.
I've stopped sharing.
Yeah, okay. I'll be sharing.
Mm.
Yeah. Are my slides visible?
Yeah, your slides are visible, ma'am.
Okay, fine. Yeah. Very good morning once again. Sunday morning, and yeah, good to see we have quite a few viewers. So I'm Dr. Shruti, and my topic for today is tech learning, tools, strategies, and assessment models for the ophthalmology resident. I thank AIOS team for giving me this chance once again to be here in this very great gathering where all the teachers from all over India are the speakers. So I don't have any conflicts of interest. Before I even start, I want to tell why I chose this topic. So I see all the students, my undergraduate students, interns, postgraduates, they are actually confused these days with there is so many options available. Technology has um progressed so much. With so many options available, they seem confused. So I would say that the problem is not of scarcity, but it's of abundance. So unless we plan well, there is a very big chance that they get lost. So I thought I'll make it a little simpler for our postgraduates to plan their studies and assessments. Okay, so the presentation would go something like this. We'll define what is STL, see the domains for which we can use tech-based STL, list the different platforms available, demonstrate a few apt ones, strategies for implementing these, then we'll move on to assessment models and role of AI in STL. Finally, we will conclude. So to start with, if you see anything, we start with the definition, right? So yeah, as it goes with definitions, this one is also a pretty long one, sounds very boring. But if you decode this definition, it says a process in which individuals, so by individuals here, we mean you all postgraduates, take the initiative with or without the help of others. So STL doesn't mean that it's all on your own. You can take help of others. So who all come in this others? Your, of course, your teachers, your guide, facilitators, senior residents, even your seniors. In fact, when we were postgraduates, we have learned a lot from our seniors and even your batchmates. So they can help you in this process. So you have to define your needs because what is difficult for the other person may not be the same for you. You have to formulate the goals that you want to achieve. The resources, you have to list what are comfortable for you. And then you have to have a strategy to do it. Finally, you have to evaluate. So, SDL means all of this. And today we will see how we can use technology to make this SDL more effective. So, is it relevant to ophthalmology postgraduates? Is it? Well, very much, right? Because post-graduation is all about self-directed learning, where teachers are mainly facilitators. So, of course, self-directed learning is very apt for postgraduates. For our department, for our subject, which has very fast changing concepts, multiple machines, gadgets, algorithms, microsurgeries, we all need to be very updated. In fact, it's not just postgraduates, it's all of us who need to be updated because sometimes our postgraduates know better than us when technology is concerned. So it is very apt for ophthalmology. Now let's see where all we can use the technology based tools, SDL tools. Learning theoretical concepts. So thereby it will help you to write theory exams. Learning clinical skills, surgical skills. This will help you in turn to perform in your clinical exams, the OSCEs, which are a part of all exams now. Also to do surgical surgeries on your own later on when you start practicing on your own. The third most important domain is research, right? Research is a very important part of post-graduation. This will help you in writing your dissertation, but it doesn't stop there. It will also help you to present in conferences. I think it's compulsory now. It's mandatory for all the postgraduates to present in conference. And very important, publishing in index journals. So all of this, you can have your own tools. So where do we start from? Of course, you start from topics that you feel are important and your teachers will tell you. But a good starting point would be this. This is an NMC curriculum which has guidelines beautifully lined up for the postgraduates. For the MS course, they have all the competencies in knowledge, affective and skill domain. This is a similar one by the National Board for the DNB residents. Again, a very nicely outlined guidelines. So you can start from here. In fact, they also say first year, second year, third year, what each one is supposed to learn. So based on that, you can plan. So now let us see learning theoretical concepts. Okay, let us list some resources. We'll start with theoretical concepts. And when I say the first thing that comes to my mind is iFocus. So which has more than 500 videos, started a couple of years back. Very well, it has detailed videos on almost, I think they've covered each and every aspect for postgraduates in ophthalmology. So iFocus online, all the videos are archived. You can watch them at your own convenience. They're all by the trained teachers. Cyber site, this is by Orbis. This has lectures, quizzes, surgical videos, textbooks, manuals. You can actually take this as a course, certificate courses. After completing which you get a certificate. You can add it in your CV as well. This is one of my personal favorites, One Network by American Academy of Ophthalmology. Very helpful when I took my FICO exams. I'd use these MCQs available on One Network. So you have to first register yourself. All AIOS members can easily register. This is, I think, a favorite for all of us, right? American Academy of Ophthalmology's own iWiki. So last minute revision, last minute study before a rounds, iWiki comes to your rescue. And the best part, it is regularly updated. eOphtha by our Indian ophthalmologist, a very good source again, which has got blogs, questions, videos, etc. This is a foreign author, Tim Root of the book, which has got short and useful videos. iGuru, I found out this when I was preparing for my presentation. Not updated for last 1 or 2 years, but whatever is there, it's very useful. The resources they have divided into chapter wise: cornea, uvea, retina, anterior chamber, like that. So all the videos are there on each topic related to from anatomy to clinical concepts to advances. Now, why go elsewhere when we have our own AIOS, right? So these are the AIOS resources, AIOS own website, One AIOS, which has got, you can see, 1.7 thousand videos. So all on subjects that are apt for postgraduates. Now, for last 1 or 2 years, we have ARC taking a very active role. They have weekly, fortnightly webinars for postgraduates. The continuous updated mails come to us. This is something very useful which was never there before. ARC journal clubs. So when we were postgraduates, journal clubs were often the most neglected teaching programs. So journal clubs now they're doing it so well. PGs from all over India present in this with their moderators. I think it's a very well designed initiative. Of course, Guru Sangam, what we are doing today, a part of this is in third edition. Again, it's got lectures from teachers, expert teachers from all over India. Now, I might have missed a few. There are plenty, but I have listed a few important ones. Moving on to skills, how to learn skills and surgical training. All that I mentioned so far also have videos for learning skills. Apart from that, there are plenty YouTube videos by private channels like Cataract Coach, uh, the Deepak Megur sir's channel, some popular ones, Faco Point. So these are the video channels that help us to learn surgeries. So some of them have very detailed, each stepwise have been each video containing one step for Faco or for SICS and other surgeries. Now there are, this I told already, gonioscopy.org. For first year residents, this is very helpful when they are learning gonioscopy for the first time. One network has their own videos for postgraduates. Simulators have come again, not present during our time. Now these are very much available at premium institutes. I think each institute has one. Otherwise, AIOS sponsored simulators are available. Uh, those institutes where they are not available, I would say that all the PGs should make it compulsory to attend this SSTC and DSTC courses that are happening in all the conferences, state as well as national conferences, and they have again skill transfer courses for important surgeries, wet labs. So I request that PG should take part in this, at least register for 1 or 2 in every conference to learn whatever skills you feel you're not very good at or you need to improve in that. Now moving on to the last, this thing I was telling, resources, research, right? This is one area where technology has totally revolutionized it. We all are aware of these popular search engines like PubMed, Scopus, Google Scholar, Cochrane. What has made them different now is use of AI. All the engines now are using AI, and I will try to demonstrate a few of them further down in my presentation. So ChatGPT, Perplexity, Microsoft Copilot, then the search engines have, Scopus has its own AI. These are very helpful. Reference managers like Zotero and Mendeley, again for your thesis. The free subscriptions have limited options, but it is worth to take a paid subscription for your thesis as a really helpful in reference management. Otherwise, managing references is a big headache when you're writing your dissertation. So when you're preparing FICO, some PGs start early, right? Some of them do it after their post-graduation or later. Some do it during their post-graduation. So if you're planning any of these exams, of course, whatever I said are helpful. This is one source that I found personally very helpful, was suggested to me by my friend. So MVU PGO, it goes by this. It's totally free. So Muthuswamy sir, he manages this. You have to log in, create your own Gmail ID for this and communicate. They provide you study material, questions, and even individualized feedback, as well as suggestions about further planning. So this is very useful. So there are again various exam preparation websites like Chuvas was there during our time. So private channels on Telegram and WhatsApp. These there are many, plenty. These are very useful because you can get textbooks, free textbooks, question papers which are not available anywhere else are available on these channels. Some of these. So you have to search yourself. Usually ask seniors who have already taken exams. That will be helpful. Like for example, this was one website I found, Study for CS. Uh, Free version has limited options, but still there are good blogs about how to plan. Uh, yeah. Now, again, it's incomplete without mentioning the apps that are used. So there are many useful apps. You can see, watch videos for what all apps are available. Two personal favorites are iHandbook and the AO app. So iHandbook is useful because it has got lot of, it's like you carry everything at your in your fingertips. So it's got scales, it has got charts for vision testing, for color vision, near vision, contrast sensitivity. You can ask questions, you can put important cases which you find difficult to diagnose and ask the forum of experts to for help assistance. AO, again directly you can open IVKey through this and many other uh, the, uh, useful things are available on this app as well, and these two are free to use. Other than this, there are many paid apps. I think the very popular one is the DigiNerve, that I came to know that many postgraduates are using it, but you have to take a paid subscription, so which has got a very well planned, designed courses. Now I'm talking in this talk, I'm mainly talking about all the free options available. But the main question, can excessive learning resources cause burnout? I think all of us agree it is true. We all are suffering. We all tell our patients about computer vision syndrome, but we all are suffering ourselves. So, not just residents, it applies to each one of us because we are using technology for learning, we are using technology for teaching, we are using technology for entertainment. Now, so how to avoid this? Obviously, when you use more technology, that means more burnout. So, how do we avoid this? The main thing is to plan your studies, to plan your learning, STL, and to structure it properly. So let me show you a simple flow chart. So choose one or two competencies per week. Okay, don't have a very over ambitious schedule. Then have a talk with your faculty if they're going to help you with this, or you can do it on your own on goals, what tools you're using, and the timeline. Study at your own pace. Finally, take an assessment at the end of the week. I'll give you some examples how to take assessment. And lastly, write a reflection. So this reflection may be a new word for you all, postgraduates. Reflection is very important in practice to develop this soft skills. I think there is a talk on breaking bad news today evening. I saw in GuruSangam episode 3. So some of these soft skills is there is no way to learn them just like that. I think history taking, sir was telling that history taking is something that we have to acquire. So like that, writing reflection can be a very good tool. Over time, when you start this as a regular practice, this helps you to develop your affective domain. Now, structuring the surgical skill domain, how to structure your learning sessions. So, record your surgeries, very, very important. Okay, please record your surgeries and maintain a separate hard disk. It's a worthy investment. Your own hard disk, record your surgeries, keep them in different files, cataract surgeries, lacrimal sac surgeries, like that in different files. Use Oscar chart. It can be used for scoring by yourself as well as by your mentor or facilitator, and document it. They show the surgeries to faculty in charge if they're not present at that time when you're operating, and ask them for their opinions. It need not be the entire surgeries, even one step. You've done a corneoscleral tunnel. Show that to the faculty in charge. Let them put their comments. Record the comments, okay? And then apply these when you operate the next time. When you get the chance to do next, re-record it and make it this becomes a habit over time. So when this becomes a habit, the cycle continues till you are perfected a particular step or a procedure. This applies to procedures as well. Need not be squint evaluation, okay? So it can be neuro-ophthalmological examination. The same thing applies. Scoring chart will be different. Oscar is mainly for surgeries. So how to document this, all this? Okay, you're done and you feel that you're doing this, but instead of a logbook, since we're talking about technology, how do we document? So some institutes have their own portfolios. I'll show you example. But otherwise, you can have your own site, your own portfolio. So go to Google Sites and use this Google Sites in search to start a new site of your own, and click blank when it opens and name your site as you want, and then you add pages. So this is a very you'll have to invest maybe half an hour first time while learning, but later you can add pages, you can add your photos, you can add the videos, and this can be shared with your faculty for comments. So when we talk about portfolios, one sec. Yeah. So I'll show you that in the next slide. So now we have listed the resources for learning theoretical topics, learning skills, surgeries, as well as for research. Now we'll move on to assessment. Okay, what are the self-directed learning based assessments? When in India, mainly we think of assessment, we think of writing exams, getting good scores, passing exams. But you'll be surprised to know that ACGME competencies have more than that. Not just medical knowledge, but there is patient care, there is professionalism, there is systems-based practice, how well you're aligned to that. There is PBLI, practice-based learning and improvement. Interpersonal and communicational skills. If any of you are planning to go abroad, all these are very, very important. And you have to be proficient in all of this. If you're very good with your knowledge, but not very good with your communication, might not be helpful. So all these need to be assessed on a regular basis. Now, I told you about maintaining your own portfolios. I'll show you example of an e-portfolio. In my previous institute, we had this at SBV, Pondicherry. So here you can see that these are the log pages in the e-portfolio. So EPA and postings. By EPA, it is entrustable professional activities that the PGs are supposed to acquire at the end of 1 month, 3 months, 1 year, 2 year, at the end of 3 years. So there are different grades for that from 0 to 5. So that is that. Then there is daily log, patient care, procedures, seminar, journal clubs that the PGs are supposed to do. So all these pages, the residents are supposed to regularly log in the entries. So this is institutional, but what I mean is you can do it on your own also in a simplified manner. So let me show you if we click on daily log. So this was entered by my resident, wherein she has maintained the log of all the patients that were seen in the OPD. Another example, surgical video was inserted and the resident has put the steps in his own words, and then the faculty have given comments. So this helps as a record, you know where you started, how you developed, and where you have reached. Now moving on to using AI to generate assignment, right? Artificial intelligence to generate assignments. Now there is no end to this. Sky is the limit. I'll show you some examples for this. So first is, we use ChatGPT, the very common AI that everyone is talking about. So let me show you. I asked ChatGPT to form a question paper for self-assessment. And I told it So I asked it to prepare 20 case-based MCQs. See, when we ask the ChatGPT, the prompt is very important. 20 case-based MCQs for final year postgraduate. So that will mean the difficulty level should be a little higher of ophthalmology on the topic of cranial nerve palsies. So immediately within, I think it took 2 minutes to generate 20 MCQs. And I vetted them myself. They were all well-designed MCQs. So the PGs can do this on their own. The problem is the answer is right here, right? So what I did, I asked ChatGPT, I gave another prompt. I told please give these MCQs with answers at the end, not immediately after the question. And this is what I got. So there are no answers, 20 questions, and then the answers came. It even asked me if you want it in a PDF form for download. I said yes. So this is how we designed the MCQs and gave. So then I asked it to create a question paper on corneal topography. I'm just giving you random examples. So you can see it has given long answer questions. It has given Viva type questions, and it has given label and draw picture based questions. So ChatGPT can do that for you when you want to take question papers. So okay, you're done the first step now. You have got the question papers from AI, right? What is next? Who will evaluate? Okay, if your teacher has time, you can ask them to evaluate, but AI can help you there also, right? See here. Now I'll show you how to get your assignments corrected using AI. Here I've used another AI engine, that is Perplexity. Perplexity Pro is free with Airtel subscription. So yeah, so I should just a second. There's a small video. Now I asked Perplexity, I gave my answer on optic neuritis. Okay. And I asked the AI engine to evaluate my answer on optic neuritis for 10 marks. On management of optic neuritis for 10 marks. I didn't have the patience to write down the whole answer. So I got this answer from ChatGPT. So I got the answer from one search AI engine and I gave it to another AI engine for correction. And I also asked it to give me feedback for improvement. So you can see it is taking, I hope the video is playing.
Yes, ma'am. Please go ahead.
Yeah, okay. So it took and see, this is what it had to tell. It's telling me your answer is well structured, covers many current aspects. Then it goes on to give me what are the strengths of the answer. Okay, so coverage is good. There are diagnostic advances, but it also tells later the improvements, areas of improvement. So side effects or limitation should be given, conclusion sentence should have been added. So it then finally gives a summary. Answer is content rich, medically accurate, covers all recent advances effectively, and so and so, and it gives you improvement. Does it stop there? No. It goes on further and gives you two more options. It says generate flashcards, quiz me on this topic. So let's see what is this flashcard. I went ahead and I clicked generate flashcard option. Okay. So it was thinking. If it is showing it's thinking, it's good. That means it is working hard and the content is going to be more reliable. So it went ahead and it generated this flashcard. Yeah. So there is a question and then you press, there is an option, press to flip back. Okay. So if you press, immediately it gives answer. Then there is next question, explain the role of so and so, it gives an answer. So after this, I decided to explore the next option of quizzing. So I went ahead and asked ChatGPT, AI engine for quizzing options, wherein it gave this MCQs immediately, right? With recent clinical trial, so and so. Now, randomly I was clicking. So if you give the right answer, it says yes, and it says it is right and why. If at all you've given the wrong answer, it also says incorrect and it gives an explanation. So this is a very good. So you have written, you studied a topic, you want to write a long question, you can get it corrected. In addition, it will give you extra options of generating flashcards, doing MCQs. Okay. Now, yeah, that we saw how to do the corrections, right, in assessment. Now, moving on to getting ideas for new research. I said AI has totally revolutionized the way research is done now compared to what we did as PGs. So, especially the last 1 or 2 years, it's been totally different. It's changed. So creating ideas for new research, I'll show you one example using Scopus AI. Okay, we have Scopus prescription through the institute. So when you go to Scopus website, scopus.com, there is this option, sorry, of Scopus AI. You can see here. So you have to click there. Okay, then put your query here. There is also an option you can see of deep research here. We will come to that after a while. First, we will just put it in a normal Scopus AI. So I have put a query here about comparison of different intravitreal agents in treating CNV. So you can see Scopus takes little more time because it's a research AI. So it has to do a proper search. First it does natural language search, then the keyword search. So after that it starts generating. So as it generates a summary, on the right hand side you can see it gives references. Okay, so that means this is very well referenced. These are all reliable sources which you can totally trust, because when you're doing a research, you need properly referenced stuff. You can't just write Google research stuff, general stuff that you get on Google. So you can see it makes even beautiful tables, and in conclusion, and this doesn't stop like other AI engines. It goes on and gives you an extra options. What are those? It says concept map, it says topic experts, emerging themes, and it says you can go deeper. You want to do a deeper search, you can do this. So I was interested, I clicked on concept map. It went ahead and showed me this. Yeah. So you can see how intravitreal agents, it has made a map wherein it has divided them as a mechanism of action, type of agents, patient demographic. You want any of this, you can click on one of that for a detailed explanation. There is an option to download as well, if you can see. Now, if let's say you're doing your thesis is related to intravitreal anti-VEGF agents for CNVM, you can ask it for topic experts. So on the right hand side, why do we need this? Because you have to read some very important articles which are related to your dissertation or thesis. Of the important people who done a lot of research in this. So it says there to substantiate, it says citations and H index. So that means more the citations, more reliable the evidence is. These are well done researches which you can take. Now it also gives you emerging themes. So here it's given anti-VEGF in diabetic macular edema and newer protocols, okay, comparing this with intravitreal dexamethasone as some examples. So now going back, initially, if you remember, I told you there is an option for deep research. Deep search, if you go, this takes a little more longer. I think it took me more than 10 minutes. Okay, so let me go ahead. So yeah, this is much more detailed. The same topic, intravitreal agents for CNVM treatment, more detailed tables and more detailed review is what you get. This is a very good option if you're doing a seminar on that topic. In a very concentrated topic, you have small topic and you want whatever is available. This is a very good option. Deep research in Scopus AI. It also tells you what are the study scopes, what are the assumptions and limitations in the current research on this topic, right? And the best part is, yeah, this is what I liked a lot about this, suggested further research. Okay, I'll stop here. This is very important. Many a times in first year, uh, students are confused what to take for research, what to take for dissertation, because everything they think there is available, there is already, it is done. So how do we proceed? So this one can be a helpful one because it says what has not been done, what are more like gray areas in that region, which you can pick up for your thesis or dissertation. So suggested further research. So that is about Scopus AI. There is a lot more. I will, for the time factor, I will move ahead with this after this. So yeah, so role of AI, I don't have to tell now separately. I think we saw the role of AI. AI has a big role to play in doing research for PGs, but the problem here, why I have put this picture, it's a double-edged sword. So AI can help you enlighten about that topic, but it can, it can bind you to the gadgets and make your thinking ability worse. So you have to use the AI very carefully. So what are the pros of AI? Unlimited possibilities. I gave you a few examples just now. Time saving and quick. Okay, it is really time saving. We back in our days, we had to go to library, search the textbooks, write it down, and then type it out. All that is taken care of. You save a lot of time. Very useful in research related competencies, especially for research. What are the cons? Limited options in free versions, lack of reliability in some of the search engines, general search engines, which is so it's always better to use this Scopus AI type of engines because they're more reliable. The most important for me, the most important con is it affects the critical thinking ability. I think all of us will agree on that, that AI makes, the more we depend on it, the less is our critical thinking. So it starts dropping. Now, so how do we manage that? So with that, I will conclude how do we manage? We manage by properly structuring our presentation, our plan, our study plan for all the things, that is for theory, for skills, as well as for research. So we have to have a proper plan, as I said before, and execute it. I'll just show you here what happened when I was problem with AI. I want to give you a live demonstration. So yeah. Now this thing, this flow chart, I created at the last minute. I had these as blue bullet points and I decided to do a flow chart. And I asked the AI, ChatGPT, I gave the points and I said, please make a flow chart for me. You can see there are some glaring mistakes, right? Tools and timelines, it got missed, competences got, I only realized it when I started in the morning. I was about to start, I saw, okay, there is a mistake. So I thought, okay, I'll keep it. So AI, you can't close your eyes and tell the AI you ask the AI to make a PPT. You can't take it and go and directly present it the next day. You might end up with something like this. Okay, so please beware before you give complete control to artificial intelligence. So I think with that, I will conclude my topic. Just a second, last slide, yes. So I would like to say that textbooks and teachers still are the best resources to learn from for a postgraduate. Although my topic was technology-based self-directed learning, but these two T's never forget. For your concepts, nothing like a textbook. For a proper knowledge, nothing like a resourceful, knowledgeable teacher. Nobody can replace, no AI can replace a teacher. But we have to agree that technology has revolutionized the learning process. So we can't say that, I will not learn AI. I'm good with my textbooks. We have to be updated. Otherwise, the world will move before us. So what I would say to the postgraduates, stick to 2 or 3 websites or AI engines or apps that you are comfortable with, that works the best for you. Don't explore each and everything. Avoid getting distracted by notifications from other apps while using gadgets to study. This is very important. So I would say better use a laptop when studying than a phone. Less chances of getting distracted. Excessive use of technology can lead to significant wastage of time. Although I said time saving is a pro of AI or technology, but then as I said, I repeat it, it's not the problem of scarcity, but problem of abundance. There are 100 webinars, there are 100 articles. So don't get lost. Just because there are so many resources, you don't have to read each and every resource. So just stick to what you're comfortable with. And with that, I will end my presentation and I'll stop sharing. Thank you so much again for giving me this platform.
Thank you so much. So the topic is open for a discussion by the expert panelists. Dr. Sanjeev Kumar Mikkel, sir, you want to add something?
Dr. Shruti, it's a very nice talk. In fact, several
Thank you,
things
sir.
to learn for like for the old people, like old timer people, several things are to be learned actually from here,
Thank you, sir.
particularly that e-portfolio part. That's something good. Like I had several things to discuss, but in the slide with your conclusion, that made it clear. So there is nothing left for discussion now after that. Only thing is that a few points, like one thing you mentioned, one of the more actually of that site, that is the ICO platform, International Council of Ophthalmology, that also has several informations. And
Yes, sir.
that simulator tools like that wet lab, there is no substitute of wet lab. If one
Yes,
has a
sir.
facility for wet lab for training, so that should be actually mandatory for resident training. So that's the
Yes,
thing I feel. And nowadays there's a trend in the residents. I do not know at your side, but other places, but they are actually adhering to, I mean, this all AI and other things. For seminars also, they are downloading those images from there. And for even we get several theses from other places. So it appears that they are from AI. It appears at times I think there is a checkup also, like we can test whether this is done from the AI or not. So those things should be discouraged actually. And because in the crux, the only thing in the last is that basically that, as you mentioned, critical thinking, it affects that critical thinking and recall. I mean, this is said it will all lead to dementia. So those things are important.
True, sir.
So we have to
True,
keep
sir.
a check on that. Thank you very much.
Agreed, sir. Agreed, sir. Especially what you said, I would just like to highlight what sir said. Writing thesis completely on AI, like, taking help of AI. I want to tell PGs, please beware, because now, like a plagiarism check, there are softwares which can actually detect how much of this is being done with AI. So especially the good journals, index journals, they refuse it. If you used AI completely to write an article, it can be easily made out. So you have to be smart enough where you're using AI. So basically, don't make yourself weak because of AI. Use it for your advantages. Yes.
I think,
Thank you,
ma'am,
sir.
I would just add this that you have made this entire presentation so resourceful. I think it must have taken to you so much time to put all these resources in one place. You have
Yeah.
covered everything from in all specialities also. So hats off to you, ma'am. It was very
Thank
well
you.
put.
Thank you.
Yeah,
Thank
I
you.
also appreciate Dr. Shruti. Well done program. So as you told, the creativity, AI should not kill the creativity of a student. That's what I feel. And also finally, the student has to write the examination and take the Viva part. So that AI should be used as an adjuvant. And the points you
Right.
mentioned using Scopus AI, that's also very well appreciated. So they can as well use AI as an adjuvant rather than the main screen, I feel.
Yes. Totally agreed.
Yes.
Naina, ma'am, would you like to
Yes,
comment
yes,
as well?
yeah. Really a wonderful presentation for me. I have done thesis on typewriter. Imagine how much it has evolved in leaps and bounds. And this was a learning for me too. What I have to say is that in this plethora of resources, the students shouldn't get confused, and they should plan, as Dr. Shruti said, plan and go ahead. But one point which she emphasized, which I would also like to say, that they are taking inputs, using all these things to take inputs and learning. But another important thing of learning is self-reflection. So what important thing she has told is that record your surgeries on hard disk. That aspect is equally important. So we should not lose touch that we are here as surgeons, we take inputs, but we have to analyze and assess our performance. So I think that is a take home message for all.
Yes, ma'am.
Yes.
Thank you.
Thank you. So when I used to be a postgraduate, self-directed learning especially was helpful for the final paper, the newer advances in ophthalmology, because the questions usually would be like something we really do not have it in practice. So yeah, all right.
Yeah.
So moving on, I invite Dr. Tasneem Suraya to deliver her lecture on drawings and color coding in ophthalmology.
Shall I share my screen, ma'am?
Please go ahead.
Screen is visible now?
Yeah, the screen is visible.
So good morning, everyone. Topic is on drawings and color coding in ophthalmology. So no financial interest and conflict of interest, nil. So starting with history, the drawing was first started by Dr. Charles Shephens, who was the discoverer of indirect ophthalmoscopy. He first started the retinal drawing, which was followed by the Braun and et al. For drawing the corneal diseases, who complemented a simple scheme for the corneal diseases, and which was followed by the systematic method of drawing corneal diseases by Baring and Leibson. And what was the significance of this color drawings and coding in ophthalmology? First of all, the documentation. See, many medical legal importance, any case sheets, we have to be very particular about our findings. So it helps in documentation, which helps in the standardization of our findings. And second one, and follow-up of the patient's eye condition. And third one, as a teaching tool in our institutions. Okay, they can be better. The lesions can be better taught using this color coding. And fourth one is patient safety. Patient safety means we have to follow the patient, and also we can take care of the patient's condition using this, and enhances the skill and observation. Okay. Then coming to the color coding, we have anterior segment color coding, we have posterior segment color coding. And anterior segment we have cornea, lid, conjunctiva, glaucoma, that is called goniogram. And posterior segment we have retinal color coding, there is a Du Bois-Amsler's chart. Neuro-ophthalmology we have diplopia charting, Hess charting, and finally a word on ocular pharmacology also. So coming to first the corneal color coding. So the corneal color coding we use in and out our slit lamp and torchlight. So by putting torchlight or a diffuse illumination in the slit lamp, you can have a frontal view of the cornea, and you can supplement it with the corneal diagram. And again, you can put a slit and you can obtain an optical section of the cornea, lens, anterior chamber structures, and you have to see a slit view. So we will see one by one how to draw corneal diagram and the color codings. So the left-sided picture is the real cornea, and the right-sided picture is how you are going to draw a corneal diagram. So you draw a black circle that depicts the cornea, and central dotted circle is the pupil, and you have to divide the cornea into quadrants to qualify and quantify the lesions. So we will see the color coding. First one is the blue color. So where all we use blue color? We use blue color especially in cases of corneal edema. Okay, so we use blue wavy lines to represent Descemet's folds, blue shade to represent the stromal edema, and small circles to identify the epithelial edema. So we will see some cases also related to it. See, the first case, the slit has been put in the cornea, and you can see the DM folds, and it is marked in the corneal diagram as a blue wavy lines. And you can see in the right side picture, the diffuse stromal edema, you can give a diffuse blue color, and for epithelial edema, you can draw blue circles. Kids draw blue circles, and you can see a bulle with a large circle. Next, coming to the green color. So any epithelial defect, erosion or ulcer, you put it in a green color. So you can represent a punctate epithelial keratopathy, you can represent an epithelial defect, and small lines or wavy lines for showing the filaments. So you can see the first picture with the SP case, you can see dotted green, that's a green dots in the cornea representing the SP case. And second picture, you can see a filamentary keratitis. You can see in the picture we have drawn a green wavy lines. And third picture, this is the Dellen. There's a corneal thinning you can represent in green color at the edge of the cornea, just at the junction of the corneoscleral. And fourth one is the epithelial defect. So epithelial defect always represented in green color, and the central yellow color represents the infiltration. Then comes the red color. So we all know any hemorrhage, any vessel, we mark it with the red color. So we have, first of all, vessels. We have live vessels, ghost vessels. So live vessels always continuous line, and dotted lines represents the ghost vessels. And so we can also differentiate the differentiate the vessels as superficial and deep in this color coding. Superficial vessels means you will have a wavy lines, branches, and deep vessels, stromal vessels, are represented using a straight lines. And apart from these vessels, you can also represent the red dots okay, represent using a red dots, the rose Bengal stain, which we commonly use for staining the viral ulcers. And coming to the first one, you can see there's a superficial vessels in the epithelium, and here there's a drawing showing the superficial vessels with the fine branching, and the deep vessels, the straight lines, and third one is the ghost vessels in the limbus, you can see. So here you can see the dotted lines, and fourth one is hyphema, that's the blood in the anterior chamber, which can be drawn in red color. And finally, this is the rubeosus iridis, that is around the pupil we can draw some red color vessels. Then coming to yellow color. So yellow color usually represents some infiltration or some pus collection usually. So the hypopyon, that's a pus in the anterior chamber, is represented by yellow color, or you can use orange color also. And fresh capes. See, we have capes, keratic precipitates, old capes, fresh capes. So fresh capes are usually represented by yellow color, and old capes we can use brown color. And infiltrations. So infiltrations are nothing but the collection of polymorphonuclear lymphocytes and the exudates in the ulcer. So you can see in the first picture there is an epithelial defect which is represented by green color, and central infiltration represented by the yellow color. And second picture you can see the contact lens with deposits. See, the contact lens is represented by a dotted line. There's a dotted black color line, and inside yellow color you can see the deposits. And the third picture you have the fresh capes, which is represented as a fine yellow dots. And fourth picture, hypopyon, is represented in the slit diagram or frontal diagram by using a yellow color shading. The next comes the brown color. So brown always means pigments. Okay, so we represent any pigmented ulcers or old keratic precipitates, then iris nodules and synechiae. So the first picture you can see there was some Krukenberg spindle or any pigments you can represent by using brown dots. And second one is synechiae. So synechiae we can represent posterior synechiae, that is attachment of the iris to the lens, or anterior synechiae, that is attachment of the iris to the cornea, by brown color. And also you can draw rings, especially the Fleischer ring and iris nodule. So these are the brown nodules at the pupillary border, represent the copies, and these are the collarette of iris. This is the Bouzakas nodules. And finally comes the black color in corneal color coding. See, always we draw outline of normal cornea, lid in black color, and apart from this we represent any scar, dystrophies, contact lens, sutures, white hot spots by use of black color. So the first one, this is the corneal foreign body. There is a foreign body at 9 o'clock position, and roughly corresponding to the junction of 9 and 10, and they have drawn it here. And here there is a corneal laceration at 7 o'clock. So from the center to 7 o'clock they have drawn it there. And this one is the contact lens. I told there is a dotted circle can be represented. And next one is a suture. Sutures also usually drawn in black color. And finally the corneal nerves. So the corneal nerves also, which clock cover you can represent in the particular clock cover of the corneal diagram. And next one is the corneal scar. Any opacities in the cornea can be represented by black color. Then tissue adhesives. We use cyanoacrylate glues. That also we can represent with black. And third one is the degeneration. Any peripheral corneal degeneration could be represented by black color. See, any Dellen to be represented by green color, but degeneration to be represented by black color. And keratoconus with scar. So whenever we draw any corneal ulcer or corneal lesion, we should know the lid coding as well as conjunctival coding also. So lid outline, as we already see, it is usually drawn using a black color, and lashes also black color. And if you see some vessels in the lid like telangiectasia, mark it with red dots. And when there is a laceration, as I told, when there is a laceration or tear, it should be drawn in black color. And these are some features of findings in the palpebral conjunctiva. So the first one is the follicles. Follicles can be represented in faint red dots. And next one is the papillae. So papillae are a lymphoid hyperplasia with blood vessels. So we shade it with dark red color dots. And third one is concretions with yellow color. So the two palpebrae can be represented as two semicircles. Okay. Then conjunctival color coding. So conjunctival color coding, again the lid has to be drawn, the cornea has to be drawn, pupil has to be drawn, and if there is a nevus represented by brown color, And if it is a diffuse congestion, you can represent by red shading. If it is a localized circumcorneal congestion, you have to represent by a red lines around the cornea. And pinicula we can represent by yellow color. Pterygium you can represent by either red or pink color. So this completes the corneal color coding. So this is the overall picture. So I have given us every color, and finally this is the overall picture of the corneal color code. So always in our case sheets, in every case of corneal ulcers, we must emphasize our postgraduates to draw the particular corneal diagram in the case sheet. That's of very great, utmost important. Now coming to the next part of our discussion, that's the glaucoma color coding. So glaucoma, we have a color coding for the angle that is called the goniogram. That's the Becker's goniogram. So we have 3 small circles inside, 3 large circles outside. So what are these circles? So you can see here the first circle is the Schwabi's line, and the next 2 circles are the trabecular meshwork. Okay, and the dark circle which you see here, dark black circle, is the scleral spur. And finally the 3 circles inside shows the level of iris insertion. Okay, so the first one is the Schwabi's, and the next 2 is trabecular meshwork, and next one is scleral spur, and finally this is the insertion of the iris. And the color coding, how we are going to follow? Again, it is red for blood and blood vessels, and for membrane you use a yellow color, and for depigmentation and calcification we use a purple color, and pigments brown color, iris nodule, synechiae again brown color as for cornea, and the only thing different is the angle recession. Angle recession you use a black color cross. So this completes the Becker's goniogram. So next comes the retinal color coding. So the chart we use is the Dubais-Amsler chart. So all people have some confusion in drawing the retinal diagram. So I will tell a simple way. So this is how the patient is going to lie down in the couch. Okay. So this is, chin is the 6 o'clock position and head is the 12 o'clock position. So keep the chart upside down. Okay. So now the chart is 6 o'clock is facing the 6 o'clock of the chin, and 12 o'clock is facing in the opposite direction. Now you look at the eye. Okay. So now you are going to see a lesion at 10 o'clock position. Okay, you are going to see a break at 10 o'clock position in the patient's right eye. So draw at 10 o'clock in the chart. So, okay, don't overthink as inverted, re-inverted. Okay, just draw the same position in the inverted chart. Okay, so you see a clockwise, you can see a break in 10 o'clock position. Draw a same finding in the 10 o'clock position. So you have 3 circles in the Dubais-Amsler chart. The first one is the equator, second circle is the ora serrata, and the third circle is the junction of pars plana and pars plicata. So here also we have a color coding. So first in each color I will tell what normal structures to be drawn and then what abnormal structures to be drawn in this color. So red color, we always draw retinal arteries and arterioles using this, and also attached retina. So how to draw attached retina? You have to shade it with red color. Then comes the abnormal findings like hemorrhages. Okay, then retinal breaks. See, retinal breaks, you have to draw a red shading followed by a blue outline. Okay, then vascular anomalies and tumors. And where else you have to use a red cross? Red cross you can use in retinal thinning. Okay, retinal thinning you can use, then dialysis you can use, and open portion of the giant retinal tear, you can use the red color. Then next comes the blue color. So blue color, normally retinal vein and ora serrata. Usually we draw the nasal ora serrata only because the indentation are more prominent in the nasal ora serrata. We draw the nasal ora serrata in blue color. The next, what are the abnormal findings? It is the detached retina. Okay, then outline of a retinal break or a thinning. So as I told, retinal break should be marked by a red shading with blue outline. Retinal thinning is red cross hatchings which is surrounded by a blue outline. And what happens to the blue cross? So blue cross we use it for lattice. And where do we use blue curved lines? It is the rolled out GRT flap. Then where do we use dotted lines? It is the outline of the shifting fluid. Okay, so you have a subretinal fluid. To mark the outline of the subretinal fluid, you can use a red dotted lines and red circles in cystoid degenerations. Then next comes the green color. So green color, any media opacity, lens opacity, we use a green color shading. Just as we shade the attached retina with red color, like that we have to shade it with green color for media opacities. Then abnormal findings, you can shade green as vitreous hemorrhage in the green color. Then operculated tear. Operculated tear means the tear which is totally detached from the retinal braid, floating in the vitreous. That's called operculated tear. Then any intraocular foreign body, then that is like IOL. Then traction bands, fibrous bands. Then elevated neovascularization. And green dots where you are going to use is asteroid hyalosis or snowflake degeneration. Then next comes the brown color. The normal tissue which you are going to draw in brown color is the uveal tissue. And what are the abnormal findings? It is the pigment beneath the detached retina. See, pigment beneath the detached retina is drawn in brown color. Then pigment epithelial detachment, that is PEDs to be drawn in brown color. Choroidal detachment and detached retinal buccal. Then posterior staphylon. Then comes the yellow color. See, normally where do we use yellow color? We use for long ciliary nerves. Apart from that, we know that for exudates, soft exudates, hard exudates, we use yellow color. Then subretinal deposits and gliosis. Then post-cryo or laser retinal edema also we use yellow color. And yellow cross represents drusen and yellow stippled appearance represents retinoblastoma. And where do we use black color? So black, it is very easy to remember. We use only for buccal beneath attached retina and pigments. Okay, especially retinitis pigmentosa, we use black color. Then laser marks, we use black color. And completely sheathed vessels also you can use a black color. So this is the color coding chart we have in our retina clinic, which is drawn by our own postgraduates. Okay, and next this completes the retinal color coding. And next comes the neuro-ophthalmology. We have diplopia charting as well as H charting. So diplopia charting we all know to represent which muscle is involved. We are going to do this. So the patient will be seated at a distance of 4 feet from the examiner, and you have to put a linear source in front of the patient, and you are going to check the movement. So you are going to check left side, that is a levo elevation, levo version, levo depression. Then right side you are going to check dextro elevation, dextroversion, dextro depression. Then you have to check elevation depression, that is supraversion, infraversion and primary position. And the patient, you are going to put the RR, that is the red goggles before the right eye, and green goggles before the left eye. That's the Armstrong goggles you are going to put. So now you are going to show a linear source and you are going to check the extraocular movements. So when you check the extraocular movements, if the person is having normal binocular single vision, the patient will see the linear source like this in this picture. In all the 9 cardinal positions of case, the patient will see it as a single picture. But whereas in case of any extraocular muscle paralysis, there will be separation of these images. So first, what all you have to look for this, okay, why we have to look for this, and you have to look for this for finding the which side is involved, which muscle is involved. So for that, what all you have to evaluate. So you have to look for the separation of images, where there is maximum separation of images, and then whether there is any tilt or torsion, and whether the image is crossed or uncrossed. So for example, you can see here in the first picture, okay, usually we put green in the left eye and red in the right eye, but here the image is crossed. So this is a crossed diplopia. So we all know crossed diplopia occurs in certain conditions, and uncrossed diplopia occurs usually in SO palsies and LR palsies. So we can interpret using this diplopia charting for diagnosis as well as following up of this extraocular muscle paralysis. Next comes the H chart. So H chart, what you are going to do? Again, you are going to make the patient seated in front of the H chart, and you are going to analyze the 15-degree field of vision and 30-degree field of vision, and you are going to put a green goggles before the testing eye, and you are going to record the movements. And usually the shorter chart which is marked, it will be the paralysis side. So here you can see the right side is the paralyzed side and the lateral rectus is involved, and in the left eye you can see the overaction of the medial rectus. So it is a right lateral rectus paralysis. And we have completed corneal color coding, retinal color coding, neuro-ophthalmology color coding. Finally, a word on ocular pharmacology. See, our American Academy of Ophthalmology have suggested a color coding for easy identification and avoiding any mess by the patients. Okay, so they have graded some colors. See, the prostaglandins, they represent by green color, and dark blue color for beta blockers, then purple color for brimodidine drops, then orange color for carbonic anhydrase inhibitors, red color for mydriatics and cycloplegics. Then you have anti-infectives, that is antibiotics, we have this tan color, and white color for topical anesthetic drops. So color codes are very useful in our ophthalmological practice for not only studying, and also it is very important for the safety of the patient. And so hope I have done some justice to this drawings and color coding ophthalmology. We must make sure that all postgraduates to draw corneal color coding and retinal color coding in the case sheets, which improves not only their skills and observation, which also helps in their career also. Thank you so much for the opportunity. Thank you.
Thank you so much, Dr. Tasneem. It was indeed an extensive lecture on the color coding and ophthalmology, and it's very important, of course, because in practical examinations, especially, the color coding for cornea, retina is actually emphasized way too much. And even the postgraduates, if they want to score more marks, just apart from their answering of Viva, I think this is a way to go. So the discussion by the expert panelists, we'll go ahead with that next.
I also agree, and I hope that the residents who are listening to the lecture, please draw your diagrams with all the colors. And if at all your institution allows you to use colors in the papers, if you draw it with colors, it's kind of like an indication that you already know it. From what I remember, that during my residency time, we were not allowed to use colors. I don't know if the times have changed now, but it can be a thing. It's easier to emphasize that your knowledge is clear. So, I mean, that was a wonderful lecture. I wish we had something like that during our postgraduate times.
I would like to add a point like, as ma'am well depicted and stressed upon the color coding, the postgraduate student should start from the day one. See, whenever they work up the case in the evening, it's not like only for the examination they practice. And in this way, they will not miss any findings as well. And they can include this even for the theory. Not only the practical, even theory when we write the exams, no? So we
Right.
can apply this.
Absolutely.
I just want to say, sorry, can I speak?
Yes, sir.
Yes, sir.
Good, sir.
Thank you very much for making us a part of this whole session. And this last talk also, Dr. Tasneem has really mentioned what are these are the basic foundations of the ophthalmology residents. And something like that, like the faculty actually has to emphasize on this. We emphasize more on that all the paraphernalia should be the resident. They should carry a small colored pencil set with them. So it is actually with the teachers only who will actually reinforce these things in residents to carry your paraphernalia and use it. Actually, we have seen the people who use it from the first year residency, it becomes their habit. It becomes their habit. So that's it. Thank you.
Even during fellowship, it was a thing for us. We had to use all colors. And I think I follow it even now. I don't think I can do without colors. I'll end up having colors in all my pockets. So it's important to have colors around. It's so easy to understand. May I request Dr. Naina ma'am to give her comments as well?
Yes, I feel that today's topics were very essential, very important. And this last lecture by Dr. Tasneem was excellent. She has taken pains to cover everything, including diplopia charting, which the students usually don't do it. It's the job of optometrist at a place. So very well spoken today. And what I feel that we have to think that it's not only helping us score in the exams. That is one part. Secondly, what I feel is that if students draw in front of the patient and show the patient, yes, this is the problem, counseling, there and then, it also makes a huge difference.
Right.
So that is one thing I feel. And again, as Dr. Mittal said, everything should be habit. And I insist on them to carry the colored pencils in their IO box, carry everywhere. And especially after the routine duties over in the wards, they can go and practice, see patient on ward slit lamp IO and just continue practicing. So that will help them. Thank you.
Thank you so much.
Okay.
So, yeah, go ahead, Farnaz.
Thank you so much. Indeed, all the talks were very informative, and thank you all the speakers and the expert panelists for joining us today on your Sunday morning. Of course, this is the only day you get off from work, and it was really, really great to have you all on the session 2 of AIOS GuruSangam. So we have the next session, the session 3, today evening on quality systems and communication skills from 6 p.m. to 9 p.m. So Dr. Rolika and Dr. Farnaz, which is me, we'll meet you again in the evening. All right. Thank you so much.
Thank you, everyone. Thank you so much for
Thank
taking
you
out
for
your
this
time.
initiative. Thank you so
Thank
much.
you. Thank you, everyone. Thank you so much.
Thank you,
And I
everyone.
think we should thank Dr. Hunavar for just making sure that all the topics are perfectly put in and blended. So thank you
Absolutely.
so much.
Absolutely. Well thought of.
Yeah.
Thank you.
everyone.
And thank you for making us part of this.
Stop, ma'am. Have a great day.
Great moderating, Rolika.
It was Farnaz all over today. I was on the back seat.
Both of you are doing a great
Both of you
job.
did great.
Oh, thank you so much.
Thank you.
And good luck with all your other
बढ़िया.
episodes as well.
Thank you.
Thank you.
ma'am.
Thank you all the speakers for putting in a great show and great efforts.
Thank
It
you.
was learning for me too. Thank you.
Thank you. Good day, everyone.
Good day. Good day.
Good
Bye.
day. Good day, ma'am. Thank you so much, ma'am.
Thank you.
Thank you, Sunilji. Sunilji, we can close the live now.